Broadcast is now starting. All attendees are in listen-only mode.
Hello, everybody. Happy Friday afternoon. On behalf of Fight Colorectal Cancer, I'd like to join you to our update of GI ASCO 2019. We're very excited to have Dr. Dusty and Dr. Natalia joining us today to give a brief overview of the highlights related to the GI cancers and exposure of the research and clinical findings for this GI ASCO. So we are going to spend some time going through the detail. Just a quick reminder today that if you're asking questions, we'd ask that you go ahead and key those in. We will have some facilitated discussion from Sharon Worrell at the end of today's presentation. I would like to extend a huge thank you to Reese, Sharon, as well as the extended Fight CRC team, including the communications team, who will begin continuing the social media tweets and the like throughout the duration of the webinar. So great job, everybody, and thank you for all of the time and commitment. We will go ahead and remind everybody that on our Fight CRC website, there are currently a host of resources available, mini magazines, the ever popular Guide in the Fight, as well as podcasts and these webinar series that are archived on the Fight CRC site. So please, after today, go and peruse the website and download, share with friends, family. This is really great information to be shared. Next slide. Just a quick reminder that today's webinar, we will not be we will not be actually entertaining individual medical questions. So if you have a specific sign, symptom, or a question about your medical care diagnosis, definitely encourage you to talk to your healthcare provider and your team. Today we are providing general information about research, the outcomes of studies, and where we are in the state of colorectal cancer treatment and the like. But if you are experiencing signs, symptoms, call 911. And just a reminder, this is not a replacement for any of the direct medical care. Next slide. So with that, I am going to turn it over to Dr. Dustin Deming and Natalia Uboa, who will provide some great oversight of the GI ASCO 2019. And just as a quick reminder, this is a real carve out of all things gastrointestinal for the ASCO meetings. And as you all know, that the big ASCO meeting is happening this summer. So I feel like this is going to be a really good frame up for what we're seeing coming. So Dusty is part of our medical advisory team. He's been very engaged at the Carbone Center as an oncologist and also as a cancer survivor. And Natalia is a great part of the team as well, who's been very engaged in Fight CRC activities as well. And it's a huge thanks. I think both of them have also engaged our research advocates very nicely to grow all things Fight CRC. So with that, team, there we go. With that, Team Carbone Cancer Center, I'm going to turn it over to you two.
Thank you. Can you see our screen right now?
Yes.
So click on this, Dusty. There we go. Okay. Thank you.
Did the screen move? Because
can you hear him?
Yes. You guys, right now we can see a slide that says outline.
fantastic.
Yay! Success.
Okay. So welcome everyone to the webinar. We're very excited to talk about recent colorectal cancer updates. We're going to talk more about more than about just what happened at GI ASCO, but also some recent updates from ESMO and updates that have happened kind of independent of recent cancer meetings. And so today we're going to divide up the webinar in two parts. I, Dusty Deming, am going to be talking about updates in targeted therapies for colorectal cancer, and Natalia is going to be talking about immune therapy updates for colorectal cancer. And so there's a lot of exciting things going on in the field right now, and we're really enthusiastic about some of the new findings and studies moving forward. So we will hopefully have a great presentation for you today, and then look forward to answering questions and keeping on with this great work. So right now for metastatic colorectal cancer, the standard of care for patients is to have molecular testing, so testing of the DNA of cancer cells for multiple different markers. These include the KRAS gene, the NRAS gene, and the BRAF gene, in addition to looking at mismatch repair deficiency or microsatellite instability. Natalia is going to be talking more about those markers in her portion of the talk. The reason why we do these different markers is because they help us understand which therapies may or may not be beneficial for patients. So for example, the KRAS, NRAS, and BRAF, those mutations all let us know that if the cancer has those mutations, that the patient is not likely to respond to the anti-epidermal growth factor receptor antibodies, cetuximab and panitumumab. And for mismatch repair deficiency, at least one of the reasons why we look at that is that patients with metastatic colon cancer who have mismatch repair or MSI high colon cancer are very likely to respond to immune therapy options. What we're going to be talking about with these targeted therapies are actually some of the data to indicate that maybe we should be looking at additional markers beyond these. The first gene that I want to talk about is NTRK. So NTRK is a multiple genes that actually encode for proteins, or what we call tyrosine kinases. Basically, these are receptors that have enzyme activity that are actually very important in nerve cells. So these receptors are known to be important for nerve cell development and maintenance of normal nerves. What has been recently found out, though, is that in 1% of colorectal cancer, what happens is that there's a rearrangement in the DNA, or a change in the structure of the DNA, where part of the NTRK gene gets fused with another partner in the DNA. So kind of a change in the structure, a rearrangement of the DNA. And what this does is it turns on the TRK tyrosine kinase constitutively, or meaning always on all the time. And so because of this, these cancers are constantly getting a cell or a signal to the cell saying, grow, 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 divide, 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 don't stop, basically be acting like a cancer. Excitingly, there are new drugs that actually target specifically these NTRK proteins. And for this discussion, what's most important is these NTRK fusions, which are always turned on. And again, it's about 1% of colon cancer. One of these drugs that was recently FDA approved is called larotrectinib. And what was seen is that across cancer types, so regardless of what cancer type it was, but including many patients with colon cancer, when patients whose cancers have these NTRK fusions, when they're treated with this drug, patients respond very quickly, and many of the patients develop a very deep response. So it's roughly 80% of patients have some response to this therapy, and many of these patients ongoing have benefit from these therapies for many months, if not potentially years for some of them. We have an example here of one patient at our institution that was treated by Dr. Boha, who has a large gastrointestinal stromal tumor. This is different than a colon cancer, but this example shows you what can happen with these NTRK fusion cancers when they're treated with larotrectinib. This is a CT scan, and we can see a very, very large tumor in this patient. And these are the pelvic bones here on the side, and this tumor kind of sitting in the pelvis. There's also fluid free in the belly because of the cancer being there. And after treatment with this larotrectinib, in just a short number of months, this large tumor was reduced to a very, very tiny tumor, only about the size of a small gumball now, when it was previously much larger than even a watermelon for this patient. So this shows the potential power and benefit of these new therapies for this particular subtype of colon cancer. And so this is really exciting. There's a lot of efforts that have to go in to find patients with these alterations and develop therapies. So in summary, this is a new recent FDA approval for larotrectinib for cancers with NTRK fusion regardless of the histology. And routine testing is now needed for patients so that we can identify which patients have this fairly rare subtype of colon cancer, so that they can have access to these new and exciting therapies. Next, we'll talk about BRAF. So BRAF mutant colon cancer is about 10% of colon cancer. What happens in the majority of cancers with BRAF mutations is that there's the signaling pathway that connects the epidermal growth factor receptor. So this is the outside of the cancer cell, receives growth signals that turn on the PI3 kinase pathway, but also this RAS, BRAF, MEK pathway. This pathway sends signals to the nucleus of the cancer cell, tells the cell grow, 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 divide, 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 basically be a cancer cell. And when this BRAF is mutated, it turns on this pathway all the time. And so again, the cancer is constantly getting this signal to grow, 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 divide, divide, divide. BRAF mutant cancers are more common in women and typically more common in elderly folks. They tend to be in cancers that form on the right side of the colon. They can be associated with mismatch repair deficiency or MSI high status. They also tend to be higher grade, and what we mean by higher grade is that they look more abnormal than normal cancer, or I'm sorry, normal colon cells do. So some cancers that we call low-grade cancers are cancers that under the microscope, they look a lot like normal colon cells, whereas high-grade tumors look a lot different than normal colon cells. BRAF mutant cancers also tend to have spread to the abdominal cavity or what we call peritoneum. And in addition, they can often spread to lymph nodes. Sometimes what we'll see is that the cancers will spread from the lymph nodes in the normal fat of the belly to the lymph nodes along the back, and can actually march up the back towards the lungs as well. BRAF mutant cancers tend to have kind of one of the worst prognoses. So unfortunately, patients whose cancers have BRAF mutations, now it's not always the case, but for many patients, they have a worse survival because of this BRAF mutation than other types of cancers. What you can see is in this red line, the BRAF mutant group, on average, these patients live about a year, whereas with cancers that don't have RAS or BRAF mutations, people can live many years. You know, here we're talking over 36 to 42 months on average, but with new treatments, that's potentially even quite a bit longer than that on average. But not all BRAF mutations are the same. So there's a particular type of mutation called this V600E, which is a mutation that happens in the enzyme active part of the BRAF protein, what we call the kinase domain. So that's kind of the business end or business part of the enzyme. If that mutation is there, then those patients have the worst prognosis, whereas other types of BRAF mutations tend not to be not to have that prognosis. And so there's many different mutations that can happen in these genes. And so this is just a table of different types of mutations. So there's some mutations that where the kinase activity is activated, meaning there's increased activity of the business end of the enzyme, whereas there's actually other mutations that actually impair the activity of that kinase domain, such that those cancers actually tend to have a favorable prognosis. There's been many thoughts about how we should treat patients with BRAF, V600E mutant colon cancer. Because this particular type of colon cancer tends to be so aggressive, unfortunately, only about a third of the patients are able to get a second treatment. So most patients only get the first-line chemotherapy. And so one idea has been, well, if we're only going to get one line of chemotherapy in, maybe we should do all of our chemotherapy together. So this would be the combination of a regimen called FOLFOXIRI plus bevacizumab. This was, this is a regimen of all of FOLFOX plus irinotecan. So irinotecan, oxaliplatin, 5-FU, and leucovorin all given in conjunction with the bevacizumab. And that regimen has shown increased activity, especially for patients with BRAF mutations, though that has only been studied in a limited number of patients. As I said before, BRAF mutant cancers can be associated with mismatch repair deficiency. And what was shown by Dr. Overman from MD Anderson is that those patients who have BRAF mutations and have mismatch repair deficiency, they tend to respond very well to immune therapies. So nivolumab and nivolumab plus ipilimumab have been studied in this setting, and patients whose cancers have BRAF mutations do respond very well to these therapies. Dr. Boha is going to talk more about these types of therapies in detail. But in addition, there's been a lot of research over the last 5 years about what would be the best way to target this BRAF mutation. So if you have a BRAF mutation here and you inhibit it with one of these new inhibitors called a BRAF inhibitor, you can prevent some of that downstream signaling. But what we've noticed in many studies is that this actually cycles back through the receptor, so that targeting BRAF mutant cancers, especially BRAF mutant colon cancers, actually requires targeting the signaling cascade in multiple, at multiple levels. So recent studies have looked at combining drugs that target BRAF with drugs that target EGFR. And excitingly, there's new data that I'm going to talk about with inhibitors that target BRAF, MEK, and EGFR altogether that are showing great promise. So the first study that I'll talk about is vemurafenib, cetuximab, and irinotecan. This is a regimen that's more commonly now being called VIC or VIC. This regimen targets BRAF and EGFR and combines this with irinotecan. In a recent study developed through the SWOG cooperative group and led by Scott Kopetz, demonstrated that people with this treatment, that their cancers benefited from this treatment twice as long as if the patients had the prior standard of care. Now, we want the patients to respond longer than 4 months, but in this setting with a very aggressive cancer, this 4 months of what we call progression-free survival, or basically time till the cancer grows, that was still a major improvement over what was seen previously. And also there was a significant increase in the number of patients whose cancer shrunk because of this. So we're going to show a number of these waterfall plots similar to what I showed with the larotrectinib, where if there's bars going down, that means that the patient's cancer is shrinking. So with the standard of care, there were only a few patients whose cancer shrunk significantly, but with this combination, there was a greater amount. So 16% of patients had a shrinking of their cancer by at least 30%. The new exciting triple drug regimen is the combination of encorafenib, binimetinib, and cetuximab. This study was done in a very similar setting as the VIC or the VIC combination. But what you can see here is that nearly half of the patients are responding to this triple drug regimen, and the progression-free survival, instead of 4 months, has been expanded to 8 months. And so there was a very large phase 3 clinical trial that has just completed enrollment that we're very excited to see the results, but we think that this is very likely to be a regimen that will be FDA approved in the near future for treatment of BRAF mutant colon cancer, given these exciting clinical trial results. What's even more impressive with this particular regimen is that it seems to be that when you have all 3 of these drugs together, they're actually less toxic than when you have any 2 of these drugs together. And a big reason for that is that when you target this pathway, many of the side effects, including rash, nausea, fatigue, and diarrhea, all are mediated through that same pathway. And so if you inhibit that pathway in multiple ways, it actually prevents a lot of those from happening. So in summary, BRAF V600E mutant cancer, a distinct subtype of colon cancer. Again, it's about 10% of colon cancer. These patients unfortunately have a poor prognosis, and previously we've only been able to know that we shouldn't give the anti-EGFR therapies alone for these particular types of cancer. But now, excitingly, we know that the mismatch repair deficient versions of the BRAF mutant cancers will respond very well to immune therapies. And now we also are seeing evidence that new triple drug regimens targeting these cancers in different ways actually look like they're going to have great benefit for patients. So the last subtype of colon cancer that I'm going to talk about is the HER2 amplified colorectal cancer. So this is about 5% of metastatic colorectal cancer that have amplifications of HER2. HER2 is a receptor on the surface of cells that gives growth signals to the cell, very similar to the way that EGFR does. Many of you may have heard of HER2 from breast cancer, where it is a common target there, but has not been previously well studied in colon cancer. And what we see is that there's increased amounts of HER2 on the surface of about 5% of colon cancers. And so one of the research areas that's been very active over the last 5 years is, can we use the drugs very similar to the drugs that we use for breast cancer to actually treat this subset of patients with colon cancer? And what was recently demonstrated, this is data from GI-ASCO from 2017, but there's also more recent data that is hopefully soon to be published, indicating that patients can respond to trastuzumab and pertuzumab. These are both monoclonal antibodies that target HER2 on the surface of the cell. With this non-chemotherapy containing regimen, what was seen is that many of the patients respond. So about 40% of patients getting response to these therapies, and when patients respond, the duration of their benefit is quite long at 10.3 months. So this is another subtype of colon cancer where we now have potential new drugs that can be used. And this is very exciting, as you're seeing for the NTRK, the BRAF, and now for HER2 as well, is that it may be that we don't necessarily need to give chemotherapy with these drugs in order to induce a response. So an example of that is actually a patient that I have in clinic. This is a patient who had previously had a head and neck cancer and had very difficult to handle side effects from chemotherapy. And when he came to see me, he was thinking that, maybe he didn't want chemotherapy. And so we offered molecular testing at our institution. We're very fortunate in that we have a way of getting this testing for free for all of our patients with metastatic cancer. Now, that's not available everywhere, but that there are growing programs that allow people to get more access to sequencing. What we found in his cancer is that the normal cells should only have a couple copies of HER2, whereas his cancer cells had over 150 copies of HER2 there, which means that his cancer cells were expressing this HER2 receptor quite heavily. And we treated him with just one of those drugs, trastuzumab, and he had virtually no side effects from this therapy at all and had a profound response. So this is his CEA numbers coming down. They started at 7,500, and most recently they've been in the single digits. And on his CT scans, these are the initial scan and then the scan 2 to 3 months later, you can see there was a dramatic decrease in these black dots, which were cancer spots in the patient's liver with this treatment. And so we're very excited again that this is going to be a new treatment strategy for patients, and hopefully will be a standard of care in the very near future. So again, in summary, HER2 amplification, colorectal cancer is a new subtype of colorectal cancer that looks like it could be treated without cytotoxic chemotherapy. There are further ongoing studies. More data is being gathered as part of the Genentech MyPathway platform that's looking at trastuzumab and pertuzumab. In addition, there's a clinical trial through SWOG 1613 that is comparing trastuzumab and pertuzumab with cetuximab and irinotecan for patients in the second-line treatment of HER2 amplified colon cancer. So to conclude my portion of the study, there are new exciting targeted treatment options for patients with colon cancer, and it is my opinion that in addition to KRAS, NRAS, and BRAF and mismatch repair status, that we should also be testing colon cancers for NTRK mutations and for HER2 amplification. This can all be done as part of large panels. One of the difficulties currently is that many insurances are not reimbursing or paying for these large panels to be done. That's an active area of advocacy that I'm working in. In addition, I know FIGHT CRC is working on this as well, to be able to get more access to patients for these large sequencing panels, because the more we know about patients' cancers, the better we can treat those cancers. So now I will turn things over to Dr. Aboha to talk about immune therapy updates.
Thank you so much, Dusty. This was a great summary. I will give you some additional information on what has been happening and where the field is moving with the use of immunotherapy for colon cancer. So what are immune checkpoint inhibitors? The slide, it's a busy slide, but I will explain to you what these drugs do the way I explain to my patients in clinic. So the cancer cells are ugly cells that theoretically, just like other ugly cells, like bacterial cells or abscesses, our immune system should try to attack and kill. But for some reason, the T cells are not as effective at killing tumor cells as one would expect. And one of the reasons for why they're not as effective is because the tumor cells, and I don't know whether you should be able to see my cursor, have these antennas on their surface. And one of the antennas is called PD-L1, although there are multiple other ones as well. And when these antennas engage the antennas on a T cell, the T cell becomes paralyzed. So what Keytruda and Opdivo, what these drugs are, is basically the drugs that bind right here and block these antennas. So they, in a way, allow the T cells to come in then and kill the cells without the tumor cells trying to paralyze them. So, there are a few caveats that, first of all, the T cells need to be there. They need to care that the tumor cells is there, which may not be the case with some of the cancers that we're dealing with, like colon cancer. And another thing is those antennas have to be there, because unless those antennas are there, it doesn't matter whether we block them or not. These drugs will not be effective. So what are the benefits of immunotherapy? In general, we know that these drugs are better tolerated than chemotherapy. Again, chemotherapy is a blunt tool. It kills cells that divide fast. So it kills a lot of innocent bystanders. So the reason we are excited about immunotherapy, just like we are excited about the targeted agents that Dusty talked about, is because these drugs tend to be more specific for, tend to be killing the tumor cells more so than normal cells, and hence have less side effects. And the other thing that we've seen from other tumor types is that the patients who respond to immunotherapy tend to respond for long periods of time. So the benefits tend to be more long-standing. The problem is that most of the patients with colon cancer are resistant to these agents. The only colorectal cancers that tend to respond to immunotherapy are those that are microsatellite unstable, and I will talk to this in more details in the next slide. So there's a lot of research ongoing trying to figure out how can we make the microsatellite stable tumors respond to immunotherapy. So what are the MSI high tumors? So MSI high or microsatellite unstable tumors are the ones that lack proteins that correct mistakes in DNA. Again, the way I explain to my patients in clinic is if you look at the keyboard, there are backspace keys. So when you type, you can correct the errors. And the same applies to the way our DNA being synthesized in the cell. There are the proteins that have the same function as the backspace keys. And if you're lacking those proteins, all of a sudden you start to accumulate errors. So patients with MSI high tumors have a lot of errors in the DNA. And the lack of these proteins can result both from genetic predisposition because of the familial syndrome called Lynch syndrome, but sometimes patients can just acquire deficiency in these proteins. Unfortunately, or fortunately in terms of Lynch syndrome, these tumors are very rare. For stage 4 tumors, it's only 3.5% of patients who have microsatellite unstable tumors. They're more frequent in earlier stage tumors and tend to have better prognosis for early stage tumors. All of the tumors, all of the colorectal cancer tumors should be tested for microsatellite instability at the time of diagnosis, regardless of stage, just because this has such huge implications in terms of treatment, but also in terms of family members if Lynch syndrome is identified. So this is the slide that was presented by Dr. Overman at ASCO 2019. This is a summary of our prior data, and this shows what kind of activity we can see with immunotherapy, nivolumab or nivolumab plus ipilimumab for microsatellite unstable MSI high colorectal cancer tumors. And when you look at the slide, these bars show how much the tumors actually shrink. And this is pretty impressive. We just don't see these kinds of graphs with chemotherapy or other agents. And the other thing that's interesting is that the tumors become kind of frozen in time. And for many months after the treatment is initiated, they don't grow. So because of the studies like this and some of the other studies that have been conducted, FDA has now approved 3 drugs for the use for MSI, for treatment for MSI high colorectal cancer: pembrolizumab, nivolumab, and ipilimumab. If you look on the slide more carefully, you'll see that all of these approvals happened after progression on chemotherapy. And so we don't really know whether if we should use these drugs earlier in the treatment. Should we use these drugs as soon as the patient is diagnosed with metastatic disease? And in order to answer that question, there are a number of studies ongoing, and this is one of the studies that is ongoing and is looking whether we can use atezolizumab, which is a similar drug to pembrolizumab and nivolumab, either alone or in combination chemotherapy in the first line. So this, again, the study is ongoing, and hopefully we'll have answers soon, and we'll be able to move these drugs to earlier lines of therapy. The other thing we don't know is whether we should be using these trials after resection of stage 3 colon cancer. Right now, the standard treatment is to use chemotherapy after the resection of stage 3 colon cancer. But this trial, again, with the same drug, atezolizumab, should be able to allow us to answer whether we should be using immunotherapy in combination with FOLFOX after the resection. Again, the results of these trials will likely be practice changing, but they're not yet available for us, and it'll be a few years before we get them. The problem is that the success has not been as apparent for microsatellite stable tumors. This is a slide again presented by Dr. Overman summarizing some of the prior negative studies. In this study, patients were selected for PD-L1 positive tumors, and pembrolizumab had really no activity except for one isolated patient. And when we tried to combine these drugs with other agents like bevacizumab or cobimetinib, a MEK inhibitor, these combinations have shown some promising activity in other diseases. We really haven't seen much of a difference in colon cancer. This was the study that was presented at ASCO this year, and this is a study that combined 2 different immunotherapy drugs, durvalumab and tremelimumab, in patients with metastatic colon cancer. Durvalumab is an anti-PD-L1 antibody, and tremelimumab is anti-CTLA-4 antibody, which is similar to IPI, and they've been combined safely in other studies and other disease types. And so in this study, patients with advanced colon cancer that have progressed on all standard therapy, short of, I think, TAS1 or 2, were randomized to either best supportive care or combination of these 2 drugs. And this study showed that patients who were on immunotherapy, and this is the red line here, had longer survival. But if you look actually at the numbers were the difference was very limited. So again, it did not show the same type of activity we see in microsatellite unstable tumors. So is this practice changing? No. It is encouraging to see a positive signal, but we need to confirm the signal in a more robust study, meaning larger number of patients. The study allowed for 10% of false positive rate. And the other thing we need to know, what kind of treatments this patient received after immunotherapy, because that could be contributing to the results. But I think what is critical is the fact that the signal was seen, the patients had microsatellite stable tumors, and so we need to really learn who were the people who responded, because I think that's the way to move the field forward. If we can identify what made one patient respond to immunotherapy, then maybe we can use that information to try to turn the other tumors that are resistant to immunotherapy more sensitive to immunotherapy. So one way that we can try to alter and make the tumor sensitive to immunotherapy, to use radiation with it. And this has been tried in other tumor types. And it in a way, there's preclinical data and that makes sense why we should combine the two. As I told you earlier, that for immunotherapy to work, you need to have T cells care that there's tumor in the present, and they need to try to kill the tumor, and also you need to have those antennas present. And what's been shown that radiation, in a way, causes local inflammation. And so when the radiated tumor has a lot more white cells floating around trying to kill it, and also radiation causes upregulation of a bunch of different antennas on the cell. And so it makes sense to combine radiation with immunotherapy, trying to increase the response to these agents. Dr. Daming launched a trial at our institution that looks at that specific combination in colon cancer. Patients who have resectable liver metastatic colon cancer are treated with the dose of radiation, high dose radiation to one of the liver metastases, followed by pembrolizumab, followed by surgical resection, and followed by pembrolizumab to resection. And this is trying to take advantage of potential synergism, potential additive benefit of immunotherapy and radiation. And this trial has been open at our institution for over a year now and is actively enrolling patients. This is a slide that shows adverse events or side effects, and so far our data looks promising. It looks very feasible. There have been no unexpected toxicities, and surgical resection has not been compromised by this treatment. We're not the only ones who are looking at this combination in colon cancer. This is the study that I pulled out, one of the studies that look at radiation immunotherapy that I pulled out from GI ASCO presentation, and this is a study that looks at durvalumab in combination with radiation in rectal cancer, and there's similar approaches that are being done in other diseases as well. I wanted to spend a little bit of time talking about Immunoscore, in part because I was asked about Immunoscore during the presentation about a year ago, and there have been some additional information on the use of Immunoscore, potential use of Immunoscore in the future. So what is Immunoscore? So Immunoscore is really another way to tell us whether our immune system is responding to the tumor, cares that the tumor is there. And so actually, I'm going to go on the next slide too. So really, Immunoscore is a way to quantitate how many white cells are present in the tumor microenvironment, and this can be done automatically. It's objective, and you can get a score to tell whether the tumor has high Immunoscore or low Immunoscore. And it's been shown in the past that that patients who have high Immunoscore, meaning they have a lot more immune cells present next to their tumor, tend to have better prognosis. So the question is, can we use this score to guide treatment and to help decide us, specifically in earlier stages of colon cancer, whether additional therapy is needed? So this was the data that presented at GI ASCO. They looked at 1,100 patients with stage 2 colon cancer. Some of them are high risk, some of them are low risk. These patients have been treated in the past, have been followed or resected in the past. None of them received chemotherapy. And so from a clinician standpoint, I can tell you, when we see a stage 2 colon cancer in the clinic, you always are stuck with this conundrum. What should we do? Should we give chemotherapy? Should we not? There are some high risk features in colon cancer, stage 2 colon cancer, that pushes us towards chemotherapy, although there's no clear data to support the use of chemotherapy in these patients. And so the question is, are we undertreating some patients, and are we also overtreating some patients with FOLFOX, which has long-term toxicities like oxaliplatin-related neuropathy? So they looked at the outcomes of many patients, over 1,000 patients. For high-risk patients, they define high-risk patients as those that have poorly differentiated histology, meaning the tumors look pretty ugly when they looked at them at the microscope. Those that had less than 12 lymph nodes resected, T4 tumors, meaning the tumor went all the way through the wall of the colon, and those that had tumor cells present along the nerves or in the vessels when they looked at the microscope, also tumors that presented with obstruction perforation. And so they looked and see, can we use the Immunoscore to see whether the patient will recur or not? And the results are very promising. Those that had those tumors that had high risk and low Immunoscore, meaning they did not have a lot of immune cells in their environment, were the worst group of patients. The interesting thing was that those that had high risk patients, but had high Immunoscore, meaning there were a lot of immune cells in the environment, behaved similarly to the low risk patients. So what the researchers proposed that the way this Immunoscore should be used is that for high risk stage 2 patients, we need to consider Immunoscore results when we decide on additional therapy, adjuvant therapy, chemotherapy or not. So should we use this in clinical practice right now? No, not yet. I think this is a very promising tool, and hopefully we will be able to incorporate tools like this in our clinical practice in the future, so we can really tailor the therapy for a particular patient rather than just a group of patients with stage 2 disease, which is a very variable group. But so far, this is only a prognostic marker. And what that means is that, sure, it can tell us how the patients, what are the chances of the tumor coming back. However, it's never been shown that when we use that score to decide on treatment, that actually benefits patients. So there's no role for this in clinical practice yet. However, I'm hopeful that prospective randomized trials will allow us to use an additional tool in clinical practice. So in summary, what I've shown you is that immunotherapy is very active against MSI-high tumors, and because of how active it is, there are multiple trials that are trying to push these agents towards the use early in the treatment, either in first-line metastatic treatment or even after resection of stage 3 tumors. The problem is that immunotherapy has limited activity in microsatellite stable tumors, and recent studies have been disappointing. I think we need new combination strategies, such as with radiation, and there's a lot of different trials that are ongoing, and we need to look at biomarkers. We need to look at who are the microsatellite stable patients that are responding. Immunoscore evaluates how innate immunity reacts to the tumor, and it has been shown to correlate with the recurrence risk of stage 2 colon cancer, but it is not ready yet for clinical practice. So that's all the update on immunotherapy. I think there's a lot of potential, a lot of trials ongoing, but unfortunately not a lot of positive results yet for microsatellite stable tumors. I think we can take questions.
Thank you so much, Dr. Ruboha and Dr. Deming. We really appreciate such a great, thorough overview of GI ASCO.
Oh, show this. Sorry,
oh,
Dusty. Go ahead, Dusty.
No, okay.
Dusty wants us to show the picture of pancreatic cancer and bowling for colon. Some of the fundraising activities you have going on here, and this is our GI group at UW that we're working with.
Awesome, thank you so much. So we do have a couple of questions that have come through. Give me just a moment here. Let's see. Okay. Let me scroll through here. Hold on just a moment. Okay, so let's go through the questions. All right. So we had a couple questions come through about the type of testing that you all are referring to and how it's different than genetic testing. So would it be possible to get a brief description about the difference between the biomarker testing that you're referring to versus genetic testing that patients may also encounter?
So when we talk about mutation testing or molecular testing or genetic testing, a lot of times this can be very confusing because we may not be speaking clearly on exactly what we're talking about testing. So for colon cancer, there are two types of molecular testing, genetic testing, mutation testing that are important. One is what we call germline testing, which is testing in all the cells of your body. That type of testing is important to know, is there a hereditary risk or is there a risk of new cancers forming? So Lynch syndrome, familial adenomatous polyposis, hereditary forms of colon cancer, those are detected with germline testing. That's the type of testing that you would done if you've seen a genetic counselor. What we're talking about for targeted therapies and also the mismatch repair status in general is we're talking about that being on the tumor tissue itself. And so that is genetic testing typically done with what we call a cancer hotspot panel. So instead of sequencing all the genes in the DNA, what it does is it actually looks specifically for cancer relevant genes. Now this can be a small panel, so it could just be KRAS, NRAS, BRAF, which is I think kind of one of the more common ways that it's being done now. But at a lot of centers, it's now instead of a 3 to 5 gene panel, we're now looking at a 200 plus gene panel, including some of these new targets such as amplification of HER2 and the NTRK fusions.
Awesome. Thank you so much, Dr. Deming. We do have a webinar from December that talks a little bit more about the differences in testing and different types of testing. So we do have a couple other questions here. Let's see. Are there any trials that use DNA repair inhibitors instead of radiation in combination with immunotherapy?
So there's been a lot of interest in can we use DNA repair inhibitors to make microsatellite stable cancers look more like MSI high cancers, meaning can we actually disrupt how cells normally repair their DNA to make more mutations, if it is more mutations that would make the cancer more susceptible to the immune therapy. There are a number of clinical trials that are looking at doing this in different ways. Some are using inhibitors like PARP inhibitors. Some are using chemotherapy, such as temozolomide, to induce mutations. To date, the data regarding that type of strategy and its ability to induce an immune response is quite low. There is clear interest in that, and these studies going forward. We're a little bit concerned, though, about that type of strategy for a couple of reasons. One is that just because you take a tumor, a microsatellite stable tumor, and put more mutations into it, that doesn't necessarily mean that the immune system can recognize it. One of the problems is that microsatellite stable cancers have abnormalities in a pathway called the Wnt pathway, or Wnt signaling, typically due to mutations in a gene called APC. And what this does is it actually changes signaling in the tumor microenvironment that prevents the immune cells from getting into the tumor. So even if the tumor cell has more mutations, it might be that the immune cells just can't get into the tumor because of the tumor microenvironment or the cells around the cancer cells blocking their way and making things that turn the immune system or immune cells off. And so that particular strategy, though of interest and being evaluated in some clinical trials, we're still careful about whether or not that may be the best strategy moving forward.
Thank you. If you've had biomarker testing done in the past, is it necessary to have your tumor retested?
So the answer to that, in my opinion, is it depends. So in general, if you've had testing done and there is a KRAS mutation, an NRAS mutation, or a BRAF mutation, retesting of cancers that have those genotypes are very unlikely to yield anything that would allow us to change the way in which the patient was treated. Now, in patients' cancers who are what I call pan-wild type, meaning that they're normal or wild type for KRAS, NRAS, and BRAF, I do think that there can be benefit for some of those patients to undergo repeat testing because those cancers can change more commonly, and it is possible that they could change in a way that would allow us to do other treatments. In addition, if someone's only had a small panel, if they're in this, again, pan-wild type group without KRAS, BRAF, or NRAS mutations, then the larger panel also has the potential ability to lead to other treatment options as well.
And I agree. In my practice, at least, if those patients who have been treated with targeted agents like cetuximab or panitumumab, I tend to recheck their mutational status if people still well and still are candidates for therapy. And one thing to point out, it doesn't have to be repeat biopsy nowadays. You can also send liquid biopsies, like Guardant 360. I've had success with that in some of my tumors, although that's not really standard of care. But I tend to sequence everybody who, at the time of diagnosis and after progression on targeted therapy.
Great, thank you. How is the immunoscore obtained? Is it through a tissue sample?
Yes, it's an evaluation of the tissue sample. And again, it's not done as part of clinical practice, but this is a tool that's under development right now. But it's looking at the tumor microenvironment, or what's present next to the tumor. Are there even immune cells there that are infiltrating the tumor?
Okay, I think we have time for just a couple more questions. This one is specifically about immunotherapy. Are there any differences in immunotherapy outcomes for early age onset colorectal cancer patients versus patients diagnosed at an older age?
The responses to immunotherapy depend mostly on the biology of the tumor, whether they are microcellular unstable or not. We do not have any information right now to suggest that the responses are different depending on the age of the diagnosis. Certainly, patients who have microsatellite unstable tumors and have BRAF mutations diagnosed at a later age, in the past have had worse prognosis than other tumors that are purely microsatellite unstable. But in the era of immunotherapy, we really don't know whether there's a difference in terms of response right now. I don't know whether Dusty can add.
No, I think that's fair. I think we need to collect more data on what is different about patients with early onset colon cancer, and unfortunately, that subset of patients hasn't been studied to the extent that it needs to for us to be able to answer questions like this.
Okay. All right, and for our final question here, are you seeing any correlation in TMB and immune cell numbers, immunoscore, I think?
So when we look at TMB, or tumor mutation burden, in general, that can correlate with more immune cells in the tumor. The issue with tumor mutation burden as a marker for colon cancer is that outside of the MSI high or mismatch repair deficient cohort, or those cancers with POL-E alteration, which are very similar to the MSI type phenotype, the tumor mutation burden is actually extremely low. There are very, very few colon cancers that have a high mutation burden that don't also have some abnormality in mismatch repair. And so I think it's quite hard to study tumor mutation burden as a marker for immune therapy, specifically for colon cancer, given this fact.
Okay. Let's see. Time for one more.
Let's do it.
So let's see. This person's asking about HIPEC. I believe that's how you say it. Did the trial show any improvement, or do you have anything to comment about that specific abstract? It was abstract 482. Sorry, it's a little vague.
It's about HIPEC after the resection of
Yes.
virus tumors. Yeah, I think we don't have any clear evidence that we should be using HIPEC in any patients with colorectal cancer right now. So let me just step back. So what HIPEC is putting in heated chemotherapy in the intraperitoneal cavity. And HIPEC has been shown to be effective in some other tumor types, like ovarian cancer. We use HIPEC for appendiceal cancer, not necessarily because there's a lot of data to support that it works, but because this is really the only tool we have for that disease. And so there has been a lot of interest, especially from the surgical colleagues, to see whether we can improve outcomes in patients with colon cancer with the use of HIPEC. And I think potentially it is a good tool, and there's probably a subset of patients that may be benefiting from this. The problem right now is that we don't have clear data who those patients are. You know, some of the studies with HIPEC that have been done in the past were done in Europe. Apparently, you know, the HIPEC that people use in Europe is not the same HIPEC they use in the United States. So really, we don't have any studies that have shown us that if you take the patients and if you resect everything from the peritoneal cavity and do nothing else, that they do worse than those that after the resection also get HIPEC, because typically both resection and HIPEC is given at the same time. So I think the jury is still out there where exactly HIPEC therapy should be used in colon cancer patients. We have HIPEC in our institution available, and we use it in some patients. However, it is a lot of times driven by opinions of the surgeons, opinions of training oncologists, rather than really true data in the community, academic community showing that this is where we should be using it.
I agree with that. I think the bulk of data that's out there now would indicate that HIPEC should not be used as a routine standard for patients with colon cancer.
Okay. Super interesting. Thank you so much to both of you, Dr. Deming and Dr. Roja, for taking the time out of your day to share with us some of the highlights. And thank you to everyone listening live. The recording of this webinar will be housed on the FIGHT CRC website. So if you want to rewatch it, it will be there by tomorrow. Thank you so much.
Thank you so much. And thank you so much for inviting us to participate.
Thank you.